I have spoken previously about trabectome. I've never been a paid consultant. I'm not a paid consultant. I'm doing this as a favor to Sohaila. I think that they're trying to offer a good product to help people. I usually tell patients it works about 2 out of 3 times, and if it doesn't, we'll have to do something else. So I'm pretty realistic about expectations, and it's not going to get the pressure super low, but when it works quite well, and you don't end up having to see those patients very often. So that's nice. Okay, we're going to talk about the procedure for a bit. It was developed by Bearvelt, who obviously is an innovator and a very interesting guy, and he up with this idea, and then he holds the patent, as does a few other people. And this is now FDA approved for quite a while, and now is in a lot of countries. You can see really moving across the globe. Recently in China, which is a big deal. If you think of it, there is no known glaucoma that occurs because there is too much inflow. So we don't think eye pressure ever is really elevated because of excess inflow of fluid. It's really, eye pressure is really an outflow issue. And the idea behind the trabectome is to increase outflow. So if you think of the angle anatomy, you can see in this slide quite well a very dense trabecular meshwork, hyperpigmented trabecular meshwork right there. Scleral spur and then ciliary body. And just as a brief introduction, when you're doing the trabectome, if you're not 100% certain, you don't have blood in Schlemm's canal, which I'll show you, you always aim for the higher thing. You can get a little deceived in the OR. You definitely don't want to go for the lower dark pigmented one because you can cause a cleft. And so, you definitely want to, and you'll know if you're in or not, but always try for the higher dark pigment. Like obviously here you know that this is all connected, so that's pigment on Schwabi's, and then there's pigment in the angle, and you would know exactly where the trabecular meshwork is here. There's this there's this circumferential blood flow, lots of little plexiform blood vessels that are part of the episcleral venous pressure, and that's why you don't really get super low pressures, because there's some resistance at the juxtacanalicular area when you get beyond to the outflow, and then you have resistance here. So you're never going to get a pressure of 8 doing this unless you create a cyclodialysis cleft. When you're doing these procedures, you can see here, you'll see pigment on Schwabi's up high, and then you see TM and scleral spur. So again, you see how you go for the high one, not the low one. Right, because this is the darker pigmented area. The darker pigmented area is the ciliary body in this case, and you could get into a lot of trouble if you were to go in there. It really doesn't happen, but whenever you have any kind of doubt, just assume that you want to go at the upper area and pigment on Schwabi's, and then TM here in a more magnified. And again, this is just giving you the anatomic correlation. So Schwabi's is up here on the corneal edge here, and then you have trabecular meshwork. And then you go down into the angle where you have the scleral spur, which is this little growth of sclera into this area here, staining there with the blue, and then the ciliary body's back here, the band that connects the channels. There are these large collector channels that drain into the aqueous veins and then go into the episcleral venous process. And unfortunately, they're not contiguous, so there's definitely an argument to be made for the larger you can do this, the better it is. You're more likely to get more channels open. So if we were lucky, we would have just had it totally lined with collector channels, but that's not the way it is. So if you really don't do a decent job of getting 90 degrees or trying to get more than 90 degrees, you may have a less effective procedure. And so that's why we show you a technique that includes more than just 90 degrees for the most part. And again, we just saw the outflow pathways here. So Schlemm's canal, and then there are these drainage veins, and then into the episcleral venous channels. So what happens is if you lower pressure, you'll get reflux of blood into the trabecular meshwork. And this is a great clue to where to do your procedure. And I almost always can create this. You almost always, by decompressing, which we'll show, and get this to happen. So it's only rare and difficult visualization cases that you might not see the blood in Schlemm's canal, or you might not be certain of the TM. But the vast majority of time, you can do this. And just as a comment, when I started doing this, I actually went up to the OR with my colleague, and we each tested our ability to view under the microscope with these lenses well the angle. So my colleague lay there, and I imaged his, I looked at his angle, and he did the same to me. Because you really don't want to test your ability to hold this gonio lens, which is not hard, but it's multiple things have to move. You have to tilt the scope. We'll show you this. You have to tilt their head away a little bit, and you have to hold your hand properly and get the proper connection. And you have to then, like, it's not exactly up, it's up and down and forward and back at the same time that get you in focus. And so practicing that a little is really a benefit to you. So if you can get a colleague or a friend to come into the operating room, just lie there as a guinea pig, that'll be good, because you don't want on your first few cases be just figuring out how to move the slit lamp. It's like not knowing how to move the microscope. It's like not knowing how to use the foot pedals on your first few phacos. I mean, you're not as good as you are later, but you want to practice those before you get in the operating room. This is just showing you the basic trabectome layout. It's actually really easy. One of the problems you do face if you work in multiple ORs or in different settings is the nursing staff. You need somebody who really understands it. It could be you, but you know, they need to know how to load and hang everything in the order of events. It's very nicely laid out. There's a workflow sheet that they give you with this, but you want to make sure you know how to do it. It's not complicated, but you have to thread the tubing through a certain area in the machine and make sure that's threaded properly for the flow to go on and go off and things like that. There have been some nice design improvements over the lifetime of this device. The sleeve covering the stuff used to be blunt and like had a lip, and you couldn't really get in very easily, and now they've made it kind of slightly rounded, so it goes right in, and you don't get caught on your entry with the sleeve, which you used to have to kind of manipulate and push. And it's a very sharp tip, so you know the thing you don't want to do is cut the endothelium or hit the lens. Those are really the two things you could do if you weren't careful that you don't want to do and you should never do. I had one patient sit up straight in the middle of a case. I pulled out of the eye and I was fine, and I was just so thankful I hadn't cut his cornea in half, or, you know, because it is sharp, and he literally just shot it. So since then I actually taped the head down. I just do, because you know, if they go like that, I mean, okay, but if he literally, and it's funny, somebody ended up doing cataract surgery on his other eye, not me, and he shot up and did the same thing to that person. So he was like this weird, I mean, I've not had that happen with anybody else. He sat right up. Anyway, so this is what you get. You get the system, and then there's these lenses that can be lefty or righty, depending on what handedness you are. It's a very nice gonio lens, actually, and you will not have any difficulty imaging the angle structures. I mean, really, you shouldn't. And if you do, you have to think about how you're positioning yourself. There are rare cases where the iris is quite floppy or flowing, you know, into your space, and I've had occasional cases where there just seems to be posterior pressure, and it's almost impossible to get the case done. I just don't do it in that case, or I'll put some viscoelast, I'll try various things, but you know, it's one procedure, and if you can't get it done just because you started it, I don't want to run a risk of doing something blindly that I can't see. And that tip is very sharp. I mean, you really want to recognize that. It's not like you can just start, you know, moving it around the AC when things are flying up at you. And that'll happen very rarely. You want to make sure your wound is good and that you have the bottle height right and all that stuff. But if it happens, you want to be thoughtful about how you deal with it. You get a handpiece, you get the fluidics, you get this tray drape and the knife. The knife is fixed size. It allows you to do the procedure. You don't need any other knives. And there is a irrigation aspiration cannula, which is when you need to put viscoelastic in, you really need that. But in the original design, we always put viscoelastic in. But with the better handpiece, you really can get in a lot of times without any viscoelastic, and that eliminates a little bit of maybe post-op spikes and things like that. The viscoelastic, and the other issue with viscoelastic, just while I'm thinking of it, is when you engage it and start using the device, if you have viscoelastic in the area where the gold pieces are, you can get a lot of extra heating in that area, and you can notice like a little burn of the trabecular meshwork right when you start to do it in there. So if you use it, which you will, just make sure you flush. Basically, there's a flushing that you have to do, just irrigation for a few seconds. So this just shows you the way this works. So the idea is this gold tip, in theory, should protect the posterior structures, right? So your energy, which is actually just electrical pulses, it's not anything magical, goes across here and it heats and evaporates the tissues, because the tissues are very fine there. And then there's suction that's removing the pieces that you've created, whatever you've vaporized. But this is meant to protect the posterior structures, so you're putting it into the trabecular meshwork, and then the channels that are behind it are not getting heated or electrified or anything. So you're not cauterizing or damaging what you're trying to open up. And then as you go through all of this, obviously, you have this in the eye. This is what's attached, and then there's tubing that connects to the main machine, which regulates the flow and the electric, and there's one foot pedal. That button turns it on, and when you press on that, you get your electric into the pulsation, into this gap. So they're going to show you the key features of the handpiece. So there's irrigation coming around to keep it cool and keep the AC there, and there's aspiration in the middle, and then that's where the active electrode is, and that's the insulation. So that's the basic idea. It's pretty simple and basic. I mean, it's not rocket science. So the idea is to engage it in trabecular meshwork without getting engaged in the sclera. You could imagine if you took the sharp piece and shoved it on an angle in there, you might end up engaging sclera. Or, because the eye wall is round, right, you see how it's curving? You just keep going straight across, you're going to end up back here, not in the trabecular meshwork. So keep that in mind. The maneuver is to keep going in a way where you're kind of going in the circle, not in a way where you just go straight across. So when it's straight across across the AC, you can go straight across, because that's pretty flat. But then as the curvature gets greater as you go around, that's not going to work. And this is, they're scanning EM images of what's happened. And you can see there's large areas where you unroof it, and here you are, but there's no holes, right? So it's only if you get this piece too that you've created any benefit, really, that we know of, because you've eliminated all this, but you've still got a wall there, which is where a lot of the resistance is. But if you can get to the point where you get to the canals, that's what should be the big benefit of doing this. And this just shows you, this is what it looks like before trabectome, and this is after trabectome, and they're showing the energy level, which is about what I think almost everybody uses most of the time. I don't think you need more energy, and that's in the manuals and everything. And this shows that what I typically call this a cleft, even though it's not a cyclodial. It's an opening you've created here, so I don't know what else to call it, but it's a cleft pretty much. So the surgical procedure, I'm going to just go over with you. It's actually a little awkward, and you have to get used to it, because your hands are much further away from your body. If you notice this, the scope is bent away from you, and the optics are up pretty high, and the bed's usually pretty high to accommodate this, because for you to tilt it and get a good view in, you need it like this, and so the height of the bed, you end up like, the microscope, instead of being like this, is like this, so the height of the bed has to go up to get the eye in position for it. So you're sitting a little tall, and your arms are a little far away from you. So initially it's kind of like, what am I doing? Then after a few cases you feel fine, but it's not the same kind of relaxed like this. It's a little bit more like this. You tilt the scope toward the surgeon. I actually go for about 45 degrees, but 30 probably works fine. You reposition the microscope oculars. They're up a little bit like that so that you're not in an awkward position. And I usually do this, if you're doing combined, obviously, if you're doing the incision, all the preparation before, you may have it one way and then have to rotate it as you're getting ready to do the trabectome. If you're doing just trabectome, I just set up the scope this way. And this kind of shows you you're holding it in one hand and this in the other. What I always do is I make sure I have a good view before I start doing anything. So before you make the incision, I just put some goo on the eye, and I put the lens on the eye, I get position, and I look, and I make sure my microscope and everything, I'm happy with the setup, I'm happy with what I can see. And then you make the incision, and you get the probe in the eye, or the trabectome in the eye. You get your nice view, and you try to do as much ablation as you feel comfortable safely to do. And then you can do a little bit of irrigation aspiration. If you didn't use much viscoelastic, this doesn't have to be a very long procedure, and then it's a single suture. And I always do put a suture in, because these wounds are, I don't know, even though it's a 1.8 millimeter, it's not a beveled incision particularly. So this is just showing you, this thing goes in, and you can actually open it a little bit on the sides internally to make it a little easier to manipulate your hands. And then that, you can actually rotate that out. You've checked. So they're showing the incision first. I just check before I do any incisions. Just watch this one piece. So this thing, okay, they're not showing the engagement, but that's what you do. And then I don't turn it over, but they're showing people rotating the handpiece. And you can go the other way. I'd say it's probably 50-50, people who do it backhanded and forehanded versus just doing it and then doing it again further over, which is what I do. So this is a key point, and I want you to watch this. So when you go across, you're not shoving this thing in. You kind of depress it a little, and then you slide across. So you can just push in, and then you do have to jab. It's like a little jab motion to just engage. You'll feel it, you'll notice it, and you'll be done. So you're pushing it back so you've got the adjacent trabecular meshwork right next to it, and then you just do a little push. And so this shows the engagement. You see how when you push, you've pushed back so the adjacent is in your thing, and now you're set. And then you can just start initiating the ablation. Okay, so that's how you engage. Again, I told you about this arc, and this is showing it very clearly that your corneal entry has to have a fulcrum, and you have to kind of move your handpiece back a little bit as you're going around so that you're kind of staying on the edge. And you'll feel it. It'll get hung up. Like you're going around, and you'll hit the sclera, and it'll hang up a little bit. So you don't want to hang up in the sclera. Like if it stops moving smoothly, try to reorient yourself, reposition. You can even go back to the very beginning, and you can go through the same spots that you've been through as much as you like. Some people routinely do more than once, but you can go across, and then you'll know where you hung up, and you know you have to like kind of pull back the fulcrum and go around the circle like that. Like you can't just keep going across. So like you're withdrawing towards yourself, like if you're kind of coming back towards yourself as you're going around. The thing that happens as you get out to about here is visibility gets worse. So at some point, you can actually rotate the lens a little and get extra visibility and go a little further, but at some point, you're kind of weighing in your mind, should I stop or should I keep going? It's like, because your visibility is getting poor, and you don't know that you're really absolutely sure you're in the space. And when I get to that point, I just stop. Because I think there's probably marginal benefits to going a little longer, but there's real potential for badness. So I weigh the marginal benefits over the real potential for badness and choose for getting out of the eye. So here's one thing showing the blood reflex. So if you just enter and then depress and let water out, if you don't like using a blade for this, you don't have to. You can just use a barric hair or anything you want. I mean, you know, he's depressing with his blade. That you could depress with whatever you want. So now he's reformed so he can check with his gonio what it looks like, and you'll see there's a huge amount of blood in the AC at this point, in the Schlemm's canal. And you don't always get this enormous amount, but you almost always get some. And that's a great way to know where to go. If you look right now here, it's the top brown line for sure. But you know, if your view's not so great and your positioning's not perfect, you might not be 100% sure. But if you see blood there, you know 100%.
And then you raise the pressure, and then the blood is gone.
Well, you do your procedure. I mean, you put fluid in, and the thing's going. You can see the blood as you go in, and then when you're done, I mean, there's always a little bit of reflex bleeding when you're done with the case anyway. There's always some. So this is somebody just doing a trabectome alone. You get it in the eye, and then you get about halfway across, and now you can see here he's pushing in and engage. See that push and engage? That's the engagement. And then you just start pressing. You can see it turns white just like that. That's exactly what it looks like when it's going well. That's what you're seeing. You're seeing straight through to the sclera, basically, the inner wall of Schlemm's. And you can even do this like where you, and there have been times, so he's flipped it and he's going backhanded, but I find, I mean, you know, everybody has different kind of sense of instrument. Like this is very awkward, like your wrist isn't really meant to do this very much. So I just come over to the far side where I can see at the very edge and do another sweep. Because now I know my line. I know I'm just hooking them together. It's nice to start in the middle because you know that you're positioned properly and you can test it. If you do it out to the side, you don't have the same feel. But once you've done it, you know it. Now they're going to show it as part of a combined. Usually do it first because after the phaco you may not have the same ease of visualization depending on things. It's easier to just do it at the beginning. And so in these cases you frequently have the viscoelastic in because you're going to put it in anyway, so you might as well. And so you want to make sure to flush it out before you start. And so you can see as he goes over, you can see on this edge here where it starts getting tough to see, like at some point you got to stop, right? You're just not seeing anything. So you can see where he stopped, and I would have stopped there as well. And see, he thought, well, maybe I can see a little more if I twist the lens, so he's going a little further. Now, you know, the camera didn't catch it, but I wouldn't have gone necessarily that far, personally. And then he does the flip and the backhanded. But you can see how awkward it is, like the whole eye is being pulled. Do you see that? I mean, you know, people do it, so if they do it. And you can see he's got a nice ridge there. It's totally been separated. I do meiosis if I'm not doing cataract, always for safety. So I always put pylo in before the case, yeah. I'm not sure everybody does that, but I feel like it's a safety issue. So he's just going ahead and doing his phaco now. This is kind of irrelevant, yeah. So this is going to show you how it's setting up. So they rotate the eye away.
You're doing this as a standalone because you take your head away.
Yeah.
Before you drink.
Yep. So he's showing you the rotation. He's going to show you he has to rotate the scope also. And you have to fix the oculars. So you can see it's all a little higher and your arms are pretty far away. You see what I'm talking about? See how far he has to reach with his hand? And then you just hold it just like that. Like it's just your hands just sitting there just comfortably. Huh? You know, some people use a finger on the face, some people use a wrist rest. I mean, I always have wrist rests, but I don't know if I always use them. Yeah, I don't think you need them. You can use your pinky. Holding that isn't very hard, and the trabectome is very easy to handle. It's ergodynamic. It's not a problem. So you can see sometimes you don't get as much of an obvious cleft, right? He's doing it just right, but it wasn't bright white like those other ones. So you sometimes go back and just sort of make sure like he was checking by just making sure that there's an opening there by touching it. And that's it. He flips. I never liked flipping in the eye either, so that was another reason I didn't like the backhand. Yeah. So he's flipping outside the eye and going back in, which is another option if you're afraid of that. Just a little. Thanks. That's fine. Thank you. Okay. And you do want to be very careful with drawing it from the eye because you don't want to catch it on anything. But it's pretty straightforward and basic. So he's just going to do his phaco now. He's repositioned. You definitely want to see him the first day because there's often blood in the eye. It's actually pretty interesting. Like the end of the case, you can just have a ton of blood in the eye, and then the next day there's none because it can be tremendous outflow. You see him in a day, a week, a month. You know, I do use pylo. I did hear some people were using less, but I do continue to use it for a few months because I think it just helps keep the iris out of the wound while it's healing. And the antibiotic, it's interesting. The steroid, I mean, there are occasional high pressures in the very early period afterwards. I'm not 100% sure why. People thought it might be steroid related, that it was associated with it. So there's been this discussion of loteprednol. I don't routinely use loteprednol, and I just do it, you know, a very quick dose with a taper because I don't get a lot of inflammation. So I usually, you know, will tell them to use it 4 times a day for the first like 3 days and then go to twice a day. But this is what's recommended. So, and definitely leave them on the glaucoma meds initially because you really don't know how it's going to end up for a while. And you almost never get hypotony from what you've done. Yeah, I mean, so I definitely think that, you know, ocular hypertensives are a really good group for this. You know, they tend to respond well, and if you get a good response, you can avoid an unnecessary operation, which is really the goal of the therapy. I've had it work even in some uveitic patients. I'm not sure it shows a much lower overall average response, but, you know, depending on the circumstance, you can have these. I think it depends on the uveitic patient you select. So I usually select quiet uveitics who are still running high pressure for whatever reason, and that seems to have been okay. And so I think, again, each of these are just some people's clinical experience. We don't really know the exact nature of the patients and who were selected, so you have to take that under advisement. So I've had some incredibly good responses in pseudo-X, and then others where it didn't, and you know, I think that's, you know, the nature of the disease. Yeah, you really want to. It doesn't go through synechia very well. So if there is synechia present, you sometimes could, like if you have 1 or 2, you can kind of go around them or pull out, or you can try and go through it, but it's not meant for that. That stuff's kind of stuck there, and it's not as easy to get through. So this is what he says, that it's possibly a good option if you have a failed trab. It certainly means that you can have a failed trab and you can still do this. And I think it's a reasonable thing to try. So you don't have to, but you know, the only caveat being that a lot of times when you did a trab is you wanted low pressures, not pressures of, especially if you've been doing this for a while, if you wanted a pressure of 16, you would have done a trabectomy and not a trab to begin with. But if you have patients in your practice who've had trabeculectomies, it's doable. So that's Joe, who you'll all meet at some point. Joe's the you know, the lead sales representative, and he's a very friendly guy, and you'll all know him over time. So again, you know, if you think about where this fits in any individual patient, you're kind of it's obviously safer to put somebody on medicines because medicines can't lead to endophthalmitis or something bad going on with the procedure, and it's probably and one thing I've been doing, and I think you all should consider, is with MIGS and trabectome, I've stopped doing 360 laser trabeculoplasty. So even though some of these results show that it can work fine, my guess is you're scarring some of the posterior area with laser in there, even with light laser energy. So I leave the nasal aspect untreated now in my practice, just so it's not an issue. I don't know that it would be an issue, but just so it's not. In terms of cutting surgeries, you know, this would compare favorably with the eye stent in terms of the numbers you seem to be getting, although it hasn't undergone the same kind of rigorous evaluation that eye stent had to undergo. So we don't know really if you just randomize people to phaco alone or phaco trabectome, are they going to get a dramatically better outcome? We don't know that because we have these cases that seem to show it, but that's what we have. And we do know that cataract surgery alone does lower pressure to some degree, and there could be bias by indication. Like, why did you do the trabectome on this one and not that one? And maybe there was a reason that you did. But I do think it's definitely in that middle ground, in my mind, of risk between the laser and other cutting surgeries, because I think it's very low risk as a cutting surgery. I mean, you can cause harm with the tip, as I've mentioned several times, so you've got to be careful because you could cause an acute cataract or you could damage the endothelium. But other than that, you get small hyphemas and not a lot else. There can be Rare patients might come back with a high pressure that is acute. I've had one or two of those, and if that happens, you have the option to do a trab, but it is a little more urgent, and so that makes you feel bad because you operated on the patient. Now they're coming in with an urgent problem, and so that's like an emotional thing. And I do think there's a lot of patient expectation management that you have to do. So I'm very blunt. I'm like, it's 50-50, it'll work. You know, I just say that so that they, you know, when it works, they're like, oh, thank God I got the 50-50, you know. And when it doesn't, you know, it was 50-50. You know, that's the way it is. And, you know, you're almost certainly not going to have any harm from this, but we may have to go right to another surgery in a few weeks. And they're, yeah.
Would you ever consider performing on the nasal aspect if the first procedure failed?
So you could try a repeat if you thought you didn't have good visualization or something like that. I don't think it's out of the question at all. If you think you did a perfect procedure, there's not a lot more you can do differently afterwards. And you know, the truth is, it would be great in a different world where we really investigated all of these devices as they came out in a systematic way. We could figure out who fails and who doesn't. Like, I have no idea why some of my patients fail. It's a perfect case. Honestly, like, you leave the case thinking, I did a perfect case today, and it just worked. And it's like, you know, there are cases where, and there's one case I recently did where I had to stop after doing maybe 40 degrees because her AC just showed so much. I could barely get out of the eye. I had to put viscoelastic. I mean, she had some posterior pressure phenomenon, and I had to put viscoelastic. I had to, like, cut the iris a little to get it back out of the wound. I mean, it was much more than what I anticipated. And her pressure's been 12 ever since. I have no idea why. And it's been like, and she was running 30, 35, and you know, I have no idea why. Monocular patient. Anyway, so, you know, there are these cases that, you know, you didn't do well and they do great, and there are these cases you did perfectly and they don't, and that is a frustration, but I think the key is patient expectation management, because they know that there's a chance it's going to fail. It's not like you walk up to them feeling like a failure, because there is that, you just don't want to feel that way. You want to feel like I hit a home run. And like with trabs, they fail slowly, mostly. So like nobody notices that they're all failing, right? They failed over the first year and then 8 months, and then, you know, so everybody thinks you were a genius because you got 12 for 2 weeks, you know. It is a cutting surgery, so I wouldn't put it below cutting surgeries, but it's a very low risk cutting surgery. That one, you know, with cataract, I think you could argue that, but I would not argue that it would go before a laser alone as a surgery. Somebody really says, I'm not going to take any meds, do something else, you could try the laser. If the laser fails, I would consider this a reasonable next option. You know, again, since it doesn't work 100% of the time, emotionally, you have to decide how you feel as a clinician, you know, in those situations.
Do you have problems with post-operative IOP?
There can be.
Hyphema, or?
No, the hyphema really tends not to. I mean, I've had one or two that lingered a little bit, but they don't be a big problem. They tend to clear very quickly, and like sometimes you leave the case, you really can't completely get all the blood out. There's blood there. You feel a little bad, like I'm leaving an eye full of blood, and then the next day it's almost always gone, or there's a small hyphema. Yeah.
Do you see any like post-operative fibrosis?
Of what?
Within the area?
Yeah, I mean, you don't really see it. You just see the cleft. Sometimes the one thing you do see, and it can happen, is some patients, the iris starts getting stuck in the space. And so one cause of failure is clearly the iris getting into the space. That's why I think that prolonged pilocarpine period is a good idea. Because I think it must be a little sticky afterwards for a while. And if, you know, some patients where they're just doing great and they don't mind taking pylo, like I'll have them take it at night, once a night, just to keep the pupil out of the thing. Right? We all have our own cocktails and stuff. Yeah, it's an art, and it's what you think works.